Hi, this is Justin in partnership with Rolling Out Health IQ, where we discuss some of the major topics affecting African American and people of color as far as health is concerned. I am here with Dr. Melvin Echols. Dr. Echols, it's so nice to have you here today.
Hi, happy to be here.
Dr. Echols, could you give us a little bit more about your background and what you do for a living?
Okay, so I am a cardiologist, the technical term associate professor of medicine at Morehouse School of Medicine, but I'm a general slash heart failure clinical trialist, cardiologist, and so that means a lot of different things. I actually went to Morehouse Medical School and actually graduated in 2002. And so coming back to Morehouse after extensive sort of period of training and some sort of leadership work, I was happy to be back in 2019. Originally from North Carolina, rural South. So I'm very much aware of the demographics of cardiovascular disease in rural regions.
So what inspired you to pursue a career in cardiology and how did your journey lead you to this role?
Growing up in Ivanhoe, North Carolina, we were able to actually experience the not so great side of cardiovascular disease. So particularly things like sudden cardiac death and acute sort of presentations for heart attacks. Unfortunately, I've seen quite a few family members with that. But I think more so than anything else, the science was really interesting to me as a kid. And my mom brought these encyclopedias. I don't know if anybody knows what those are anymore, but there were 26 sort of volumes of books that were kind of like I guess today's Google. And whereas my brothers were out, sort of, joking around, I'm in the house in July sweating, like, turning pages in a encyclopedia about science because that was what was interesting to me. So, fast forward some odd years later, and here I am.
So when you talk about that's the interest in science, I mean, that's amazing. I think being able to understand and know, how you feel about something at that age is a common denominator with a lot of physicians, a lot of researchers, a lot of leaders in the space. Um, from there, then, what challenges did you face to trying to become a Black physician in cardiology, and how did you overcome them? And then ultimately, like, kind of what advice would you give to residents or students who are interested in being just like you?
Also, I think that there will always be challenges, especially when you're trying to do something that is not sort of the standard pathway that you are used to seeing everybody sort of follow. Um, I remember coming home on a school bus ride. So again, rural North Carolina, an hour and a half bus trip to and from school every day. And we were sitting there, and people were kind of asking, "What do you want to do when you grow up?" And I was like, "Yeah, I want to be a cardiologist." And people looked at me and laughed as if that was like the hilarious like joke of the season. I didn't really see anything funny because I had already read about it. I was already exposed to what it was going to take to get there. I knew it was going to be 12 plus years after high school. I read that. So for me, it was just sort of a matter of just kind of, checking the list and putting one foot in front of the other. Again, says nothing about personal challenges, individual challenges, which there were many. But I think it's about sort of being resilient and realizing that no matter what happens, if you're still here, you always have another chance to try again.
So then, to that point, that resilience, that fortitude, right? Can you share a defining moment in your career that basically said, because I mean, it takes a while, right? And 12 years, right? I mean,
Yeah.
is there a moment or a time where you were like, yes, this is it. Like I'm not crazy. Like this, I knew this was here. Like I knew it. Oh my gosh, thank you, God. Like, oh, I knew this was it. When I was a kid, I thought this was it. I mean, I've signed my name a bunch of times, but this is the yes.
It's so funny. I had multiple kind of pseudo moments of that. I remember walking into the building at Morehouse as a fourth year and chuckling to myself, "Oh wow, I'm going to be a doctor in like 3 months." Um, but then my best friend in the world, my grandmother, passed 3 days after I graduated from medical school, and it kind of took on a whole new meaning. So sort of starting off the career with that was a little bit rough. But I think one of the great things about just being in a family that loves you for you, that that love itself does wonders in terms of empowering you to just keep going. And to that end, just recently, 2023 had a just out of the blue sort of random kind of outpatient procedure that I needed, and ended up having a complication, and ended up in the hospital for 4 months on the ventilator for three dialysis for 3 months. Lost 150 pounds, had to learn how to walk, talk, eat, everything again. Had to depend on everyone for every single function of my life for 6 months in 2023. And I thankfully, actually, I was even on ECMO, which is a very complicated sort of circulatory system that is required for people who have sort of kind of worse and damaged hearts. But I was so sick, and my mom came down, everyone came down, and was just completely shocked because this just happened out of the blue. And I had to come from that back in 23, and not knowing what the next day was going to look like, or if there was going to be a next day. And that was the defining point in my life where I realized I love patients before, I love my patients before, but learning how to walk in a patient's shoes who happens to be critically ill is is a whole nother game in terms of relating to what it really takes to be resilient as a patient. So I carry that with me. And let me just say, I am so grateful to God that I have limbs and mind. I'm still writing. I actually wrote a piece about this, about sort of risk relevancy and what it means to patients whenever you're talking about procedures and things like that, because patients don't assume that risk until it actually happens. And so, I'm not saying to be afraid of procedures, but I'm telling you to know your procedure and know your doctors. Granted, complications happen. And that's why I'm in this space where I feel like I'm blessed, because I get to share this as a cardiologist who's, suffered a complication. But at the end of the day, complications happen. So we have to learn how to um, not live our lives in hate and blame, and live our lives in prosperity and forward thinking. And that's what I try to do.
Well, that's amazing. I am so glad that you pulled through. Really appreciate you sharing that. Um, to that point, we were saying a lot of adjectives, a lot of strong words, a lot of things that we would see. But again, just top three skills that you think can make a great cardiologist, just beyond medical knowledge. What comes to mind?
First thing is listening. Um, you cannot be a good doctor if you do not know how to listen to patients. As a matter of fact, that's the most important thing. We can always look up facts, we can always look up trials, but if you're not hearing what a patient is telling you, you're starting off on the wrong foot. And so I've always taught people to, my trainees and what have you, is when you walk into that door, you open that clinic office room there, you have about 15, 20 minutes with that person or couple or people, and you have to make the best of it. Whatever is going on in your life and whatever is going on outside those walls have nothing to do with that patient. Your job is to figure out what needs to happen, get them invested, get them engaged, and keep it moving. So I think being a listener, being vulnerable, learning how to share parts of your story that can be inspiring. When I have patients in the ICU and I'm telling them, hey, 2 years ago I was right here looking at exactly like you, probably worse. Um, but God is good, and so I think it definitely has weight to it. And then last but not least, we know what environment we're in, and quality is quality. And as long as you are able to live your life, making sure that you're doing the best that you can, and that's the quality and that's the standard, be proud of who you are, because that is the standard. Quality has always been the standard, not DEI, quality.
So to that point, for residents, and just thinking about, you know, how they can benefit and move forward and realize their dreams, correct? Because I mean, at that point, it's probably something that they've been thinking about for a very long time. Um, just basic networking opportunities and mentorship in cardiology. What are your thoughts on that? And I guess just even some misconceptions about cardiology. What are some of the things that you wish residents would take advantage of or just understood more um, as they matriculate on to becoming heart champions, what I like to call them?
Yeah, well, I think that's a great question. I think it's more so about the exposure and the inspiration. Um, I don't really think I ever saw a cardiologist growing up. I saw a doctor sort of in the field, but never saw a cardiologist. Again, I was fascinated by the science and what was going on with my family. But as the chief DI officer for ACC, we are now sponsoring internal medicine sort of exposure programs for certain groups that actually have not been exposed to medicine and to the world of cardiology. And so, for instance, the underrepresented groups in medicine that are actually, you know, a thing. We actually developed those groups to actually build out a psychological safety so that they could see people in that space that look like them. So that means African American, Black cohort, women. We have a separate women cohort. We have a separate Indigenous people, Native Americans cohort. Small, but we've been running it for the last 3 years. We also have a small LGBTQ cohort so that people can walk in and see cardiologists of all kinds that are doing what you want to do, and giving you the sort of engagement and the empowerment to say, yeah, you can get here. So that means so much to people who think they may not be able to get there. I would say not to listen too much to the fluff. I think we're going to hear all kinds of stuff. Misinformation is one of the worst things that can happen to a sort of aspiring young cardiologist. We do know that from the AAMC numbers, medical student, Black and Hispanic medical student applicants are now back to below pre-pandemic levels because of the messaging. And so we have work to do, but it is what it is.
To that point, I like to. I'm a futurist. I believe in the ability of technology to really destigmatize a lot of things and inspire folks. I think using technology as a pull through for millennials as a way to look to believe in the power of modern medicine. I think medicine is a technology. What are your thoughts on technology as it relates to cardiology, such as AI, telemedicine, and how do you think these pieces of technology are shaping, cardiology care in the future?
So I am also the co-director right now for a AI fellowship for actually full-time clinicians of all kinds. So it's a part of the Aim Ahead NIH sort of grant, and the fellowship is called CLINAC. And essentially what we're doing is basically, although they're full-time doing their own thing, we're trying to sort of give them the foundation for some of the AI sort of technology. It's based on an asynchronous kind of synchronous kind of hybrid webinar, as well as a required kind of almost capstone project that they work with on their mentor with their mentors on for about a year. So we're in the process of that now. We're almost in month 4. Um, and what I will say is, I think AI can be an amazing addition and supplement to medicine. But as anything, it's a test and it's a tool. And if you're not quite sure how this tool is designed, then you run the risk of actually using the tool in not the most optimal way. So, case in point, if this tool is not designed to detect bias or detect things that will um, increase the likelihood that groups will be left out. If you're not sort of in that space and you don't understand how to sort of evaluate that, then you run a risk of actually perpetuating these disparities that are already here with the digital divide that we know of. So I think that's one. The other thing that I'm a little concerned about is because trainees see AI sort of do wonderful things in terms of pulling up facts and putting together sort of diagrams and pictures in their minds. I'm wondering if they are considering that they're learning that information. One of the problems is just because you see it doesn't necessarily mean that you're organizing it or you're storing that memory in the most correct way to actually apply it. So more to come on that. I've been working with the cardiology fellows at Morehouse since 2019 to make sure that they know the science and that they know why they're doing what they're doing. So to be continued.
Definitely understand that, and I can appreciate that. To that point, are there any areas of cardiovascular research that upcoming doctors should be paying attention to? And then, if yes, thoughts on that, but then also any changes you'd like to see in the medical field to improve, specifically like Black cardiovascular health over the next decade?
Great question. So yes, there are, particularly in cardiovascular, there are always new trials and new therapies that are coming out, which actually has been a little bit of a double-edged sword now, right? So now you have heart failure medicines that are FDA approved for the most part of sort of guideline sort of evidence-based, 1A or, at the very least, sort of 2A evidence. And so you run a risk of actually having at least 5 to 6 heart failure medicines at one time if you're optimally treated. So now we get to a space to where, okay, what is optimal? So precision medicine is, again, a space that I think the AI will be incredible with. So that is an area of interest for cardiology. And then for me, I do think that we need to pay more attention to heart failure and the stages of heart failure. So people really, in terms of the community, they only consider heart failure when you actually go to the hospital and you have that episode. That's the marker that you have heart failure. But in actuality, there are way more people who actually have what we call stage B heart failure, which are risk factors or structural changes already that they don't even know about, that are either uncontrolled, that are sort of slowly damaging their heart, so that whenever they become one of those 600,000 people every year that come in with new onset heart failure, now it's all of a sudden a big new thing. But actually, this process has been going on for years. And so I think looking into heart failure and the spectrum and sort of pushing the needle back a little bit more to prevention will definitely be a key. We do know that hypertension and diabetes and obesity, which unfortunately challenge the African American population quite a bit, are also heavy risk factors for heart failure. So African American men and women are more likely than any other group in the US to die earlier from heart failure and usually have less access to therapies like transplants and mechanical circulation. So access, prevention, and much more community engagement. There's an opportunity for cardiologists to actually do that. I trained in Morehouse, and the first thing they did the first year was put us in the community and get us used to talking to people about their community. And so that is what you need to do. And that spans the gamut in terms of clinical trials, when we talk about bringing people in for recruitment, I've been doing this for 15 years. There has to be a relationship and there has to be a connection.
Dr. Echols, thank you so much for your time. Really appreciate your expertise and your commitment to the community. And we'll definitely be in touch with more questions. This is Justin in partnership with Rolling Out Health IQ. Thank you.